Gonna start recording. Perfect. Okay. Okay, let's go. Today we are gonna be covering chapter 40 and 41. Chapter 40 is disorder of endocrine function. Okay, etiology of endocrine disorder. Endocrine disorder occur from hypersecretions, that is hyperfunctioning, hyposecretion, that is hypofunctioning, and non-responsiveness by target cell, that is hypofunctioning. Hypersecretions could be due to secreting tumor, autoimmune disease, or excessive stimulation of the glands by trophic signal. We have the hyposecretion, failure of or congenital absence of gland tissue, autoimmune destruction, surgical removal of the gland, or lack of a normal trophic signal. Hyporesponsiveness, target tissue dysfunction, clinical similar to hyposecretion. Cold tissue resistant. We have congenital, autoimmune, and neoplastic. Congenital is inborn genetic defect that causes excessive production of hormone precursors. Autoimmune involves genetic predispositions and environmental triggers. Antibodies made against antigen and self-tissue. And neoplastic, those are tumors, okay, most of the time. Functional disorder caused by non-endocrine disease such as chronic renal failure, liver disease, or heart failure. Tissue resistance occurs when target tissue fails to respond to hormones. Iatrogeny, everything in medicine that is iatrogeny is because it's produced by the doctor, okay? Could be a medication, treatment, any condition that produce the disease and is given by the doctors. Classifications of endocrine disorder: we have primary, secondary. Primary, intrinsic malfunction of the hormone-producing glands. Secondary, abnormal pituitary secretion of trophic signal. And since clinical manifestations are similar, laboratory results can help distinguish between primary and secondary. Sometimes also we have tertiary. Okay? In primary, gland fail inadequate hormone production, low level of circulating hormone, but blood level of the corresponding trophic pituitary hormone level very elevated. In secondary, pituitary gland fails to release trophic hormone, secondary reduction primary glands production, so both levels are abnormally low. Growth hormone disorder: we have growth hormone produced in the anterior pituitary glands, regulated by the hypothalamic release of growth hormone releasing hormone, and inhibited by somatostatin. Primary target organ is the liver. Increase lean body mass, reduce fat mass, and induce liver to release glucose under condition of hypoglycemia. Growth hormone deficiency etiology: decreased growth hormone secretion, defective growth hormone action, and defective insulin growth factor 1. Actually, this is what we really measure in patients. You have problem in the growth hormone, what you measure is insulin growth factor 1. This right here. Pathogenesis may be idiopathic or related to tumor, radiation, or trauma. Growth hormone deficiency, most clinical relevant in children, associated with birth history or prolonged labor or breech delivery. Speech delivery means that the baby come out with the feet in front, okay, not the head. Congenital malformation, chromosomal anomaly, nystagmus, retinal anomaly, middle or midfacial anomaly, flip or play, causes midline brain tumor, radiation therapy for brain tumor or leukemia, trauma to the skull, to the sella turcica, growth hormone, clinical manifestation, hypoglycemia, growth below third percentile, dental erosion delay, irregular setting of permanent teeth, thin hair, poor nail growth, greater fat mass, delayed puberty. Diagnosis: agents that stimulate growth hormone secretion in children: insulin, arginine, levodopa, clonidine, confirmed by decreased serum growth hormone level and deficiency growth hormone release in response to the above listed agents. Treatment: hormonal replacement therapy with growth hormone, stimulation of linear growth in children whose bones have no fuse. Growth hormone deficient clinical manifestation in adult: diminished lean body mass, hypersterolemia, decreased bone density. Treatment: growth hormone replacement therapy. And we have question number 1. Okay, which of the following may be associated with growth hormone deficiency in infants? What is the answer? Thank you, Micaela. The answer is A, hypoglycemia. Perfect. Growth hormone, excessive growth hormone, etiology and pathogenesis. Uncontrolled growth hormone production by a benign somatotropic tumor of the pituitary. This is more common than deficiency of growth hormone. Stimulated liver to release insulin growth factor 1, and also remember that's what you measure, okay? Insulin growth factor 1, because it's extremely hard to measure growth hormone, because normally growth hormone is secreted at night and in pulsatile fashion, so it's not constantly, it's pulsatile fashion.
So it's important to measure it to what? To realize what? That he has a growth hormone excess?
Exactly, to diagnose the patient, to measure insulin growth factor 1.
Okay, thank you.
Okay, that's why in during childhood is extremely important that you shall sleep well, because they grow during sleeping time, because growth hormone is secreted at that time. Okay, cause of regulated growth of soft and bony tissue may cause persistent hyperglycemia and increase insulin production. Etiology and pathogenesis: pituitary gigantism occur in childhood. In the excessive growth hormone, we have only those two diseases. If you have the problem during childhood, gigantism. If you have problem during adulthood, that the epiphyseal plate is closed, then you have acromegaly. Clinical manifestation of acromegaly: increased ring or shoe size. Acromegaly, remember that is wide growth, okay? In gigantism is linear growth. So people that have gigantism, they are extremely high, okay? 7 feet, more than 7 feet tall. And in acromegaly, they increase in linear, but more in wide. That's why they increase the size of the shoes, they increase the size of the head, and that also produce other problems. Okay, this is a special coarse facial feature. Okay, they have like there is a transformation in the face of those person. Okay, diagnosis, you see high level of insulin growth factor 1 and elevated growth hormone level, and treatment, surgical removal of the tumor, uh, counteracting effect of excessive growth hormone, osteotype. Osteotype is the same like somatostatin, is an inhibitor hormone, okay? And then that inhibits the release of growth hormone. Now we have thyroid hormone disorder, okay? Thyroid hormones is T3 and T4, those are the two thyroid hormones, are regulated by the TSH and TRH. I'm pretty sure that you remember from physiology that all the hormones, especially the hormones that have S, those hormones are released from the uh, pituitary gland, and the one that have the R, thyroid releasing hormone, are secreted from the hypothalamus, because the connection is hypothalamus pituitary, and then the other part of your body could be thyroid hormone, suprarenal gland. Okay, we have hypothyroidism, and etiology and pathogenesis may be congenital or acquired, majority are primary because of intrinsic thyroid gland dysfunctions. Congenital hypothyroidism is the famous creatinism, typical caused by thyroid dysgenesis, and in third world country is because of lack of iodine. Secondary as a result of defect in TSH production, and usually associated with head and brain condition. Remember that the thyroid hormone is essential in life. That hormone is essential because you need it for mentation. Hypothyroidism, etiology and pathogenesis. Most common cause of acquired hypothyroidism is lymphocytic thyroiditis, Hashimoto. The name is Hashimoto thyroiditis. Irradiation of the thyroid gland, surgical removal of the thyroid tissue, iodine deficiency. Iodine is required for formation of T3 and T4. That's why iodine is so essential. Hypothyroidism, clinical manifestation in infants, routine screening in newborn as result in increased treatment for congenital hypothyroidism, dull appearance, thick, protuberant tongue, and thick lips, prolonged neonatal jaundice, poor muscle tone, umbilical hernia. That's one of the main characteristics, protruding tongue and umbilical hernia. Bradycardia, motor extremity, hoarse cries, mental retardation. That's another typical characteristic of cretinism. Cretinism, the babies have protruding tongue, umbilical hernia, and mental retardation. Nowadays, we don't use this word in medicine. Okay, so for you as a future nurse, forget about this name. Okay?
Which name?
Mental retardation.
What do we use now then?
Now you have to call cognitive disability. Okay,
Okay.
because mental retardation, people don't feel
Yeah, they
comfortable
get
when.
offended.
Exactly, that's the right word. They get offended, and then in medicine we use what I said, I forget right now.
Cognitive,
Disability, exactly. Cognitive disability, exactly. Perfect. Let's keep going. Hypothyroidism, clinical manifestation in children and adults, decreased basal metabolic rate, weakness, lethargy, cold intolerance, decreased appetite, bradycardia, narrowing pulse pressure. Nobody know what is the pulse pressure? No? Listen, pulse pressure is when you measure the blood pressure, you have the systole, that is the high number, and the diastole, that is the lower number. The difference between those numbers, that's the pulse pressure. And my moderate weight gain. Yes, hypothyroidism is weight gain. Hyperthyroidism is weight loss. Elevated serum cholesterol and triglyceride, enlarged thyroid, dry skin, constipations, depression. Listen, this topic, hypothyroidism, hyperthyroidism, both of them you have to know everything, okay? And it's gonna be really important for your future lives because those are extremely common disease in the general population. So those are cases that you are gonna face in your daily life. Somebody put something. Difference in diastolic and systolic blood pressure. Exactly, but you have to put diastolic first, okay? Because if you put diastolic minus systolic, you are gonna get a negative number.
Wait, say that again. It has to be systolic first.
Yes, because systolic is the highest number, is the big
Okay, because
number.
you said diastolic just now, so I got confused. Okay, so it's
Oh,
systolic minus diastolic.
perfect. Because if you go the other way around, it's math. You're gonna get a negative number. It's the same number, but it's gonna be negative. Okay, let's go. Hypothyroidism diagnosis is elevated TSH. That's why you measure diagnose hypothyroidism and hyperthyroidism always. First TSH. And from here, then you measure TT and 3-4. Okay. In hypothyroidism, TSH is gonna be high because T3 and T4 are low. In hyperthyroidism, TSH is gonna be low because T3 and T4 are high. Okay, remember those hormones, they function by the negative feedback. Secondary low TSH, that's when the problem is secondary hypothyroidism. Then in secondary hypothyroidism, everything is low, including the TSH. And low levels T3 and T4 may not occur until later in the disease course. Treatment goals is to return of thyroid normal stage, most progress slowly, oral levothyroxine. That's the only medication that I know for hypothyroidism. Resolution of symptoms occur over weeks. Hypothyroidism and myxedema occur in severe or prolonged hypothyroidism, generalized non-pitting edema. Myxedema is a type of inflammation, okay? Decreased level of consciousness, hypotension, hypothermia. Hypothermia means that your temperature is low. History of precipitating events may progress to myxedema coma, that is a life-threatening condition. Hyperthyroidism. Now we are in the opposite. Okay, hypo low, hyper high. Hyperthyroidism etiology, hypoperfusion with increased synthesis of secretion of T3 and T4. Gray disease, that's the most common one. Gray disease. We have a lot of type of hyperthyroidism. This is the most common. Thyroid destruction with release of preformed T3 and T4. Hashimoto thyroiditis. Listen, this is the beginning of Hashimoto because Hashimoto is a type of hypothyroidism. At the beginning, Hashimoto is a hyper, okay? But you have to uh, put in your mind that Hashimoto is hypothyroidism, okay? Primary grade disease, autoimmune, tumor-related, inflammatory. Secondary is a stimulation of TSH receptor by TSH, hypersecretion of TSH. Usually, most common autoantibody binds and stimulate TSH receptor, leading to diffuse thyroid goiter, grade disease. Goiter is when you have like the mass in the neck. That's the goiter right there. Thyromegaly, exophthalmos. Exophthalmos is when the eyes are like protruding. That's the exophthalmos. Okay. Widening of the palpable fissure resulting in exposed sclera, lag vision change, photophobia. Photophobia is that you hate the light. Hyperthyroidism, clinical manifestation, insomnia, restlessness, tremor, irritability, palpitation, heat intolerance, diaphoresis. Diaphoresis means that you sweat, diarrhea, inability to concentrate, and weight loss. Weight loss is extremely important. Diagnosis, the same. TSH, you first measure TSH and then you measure T3 and T4. 24-hour radioactive iodine obtained study can confirm diagnosis of Graves' disease and exclude presence of pyrroneoplasm. The 24-hour radioactive iodine basically is something that you put in, like in an IV, you put that substance, that the radioactive iodine, inside of the body, and that is gonna like paint the gland. And sometimes that is used to differentiate the different type of hyperthyroidism. Okay, treatment: beta blocker, radioactive iodine is treatment also, surgical removal, and pituitary adenoma treated surgically. The treatment is according to the patient. Okay, if the patient is go to the OR, then you do the surgery. If the patient is not eligible for surgery, then you do the other medication. And also, we are missing one medication right here. That is the medication that we use. Oh, those are the medications, sorry. PTU and metimazole. PTU is propyl thyrouracil, and metimazole. Those are the medications used for hyperthyroidism. Thyroid is a life-threatening. Remember, myxedema coma is a life-threatening condition or emergency in hypothyroidism. In hyperthyroidism, the emergency is the thyroid storm. Life-threatening thyrotoxicosis that occur when excessive amount of thyroid hormones are accurately released into the circulation. Clinical manifestation: elevated temperature, tachycardia, arrhythmia, congestive heart failure, extremity restlessness, and so on. And when you have those problems, you have to give PTU. You also give propranolol, is a type of beta blocker, and prednisone, that is an steroid. The 3 Ps. Hyperthyroidism, thyroid storm treatment is right here. Aggressive management to achieve metabolic balance, anti-thyroid drug, beta blocker, fluid replacements, surgical, fetal if not treated. Adrenal cortex synthesis. We have glucocorticoid, mineralocorticoid, and androgens. You know the adrenal, that the cortex have three layers. I mean, the outer layer, they produce glucocorticoids. The middle produce mineralocorticoid. Oh, sorry, that is not in order. Okay, the outer layer produce mineralocorticoid, that is an aldosterone. The middle layer produce glucocorticoids, that is the cortisol, and the inner layer produces the weak androgen, that is the sex hormone. Adrenal cortical insufficiency, etiology, and pathogenesis. We have primary is hyposecretion caused by the disease of adrenal cortex. Idiopathic or autoimmune Addison disease, that's the most common one, and that that disease is really known by the American population because one president used to have that disease. I don't remember the name of the president. Surgical removal. Secondary, we have inadequate secretion of ACTH, usually iatrogenic, related to corticosteroid therapy, suppress ACTH. And tertiary is hypothalamic. You see, sometimes endocrine disease have tertiary. This is one of the case. Okay, adrenocortical insufficiency, etiology and pathogenesis, congenital adrenal hyperplasia, rare cause in pediatric population because of a specific enzyme deficiency in the biosynthesis of cortisol by the adrenal, cause severe and life-threatening symptoms, overproduction of ACTH, lead to hyperplasia to the adrenal gland and excessive androgen secretion. Adrenocortical insufficiency. Early signs include anorexia, weight loss, salt wasting, weakness, malaise, apathy, electrolyte disturbances, hyperpigmentation. Hyperpigmentation because ACTH, when you increase the ACTH, is related with one hormone that produces pigment of the skin. That's why you have hyperpigmentation, hypoglycemia, and hyperkalemia. Diminished vascular tone, reduced cardiac output, inadequate circulation blood volume, and low blood pressure can lead to cardiovascular collapse. Diagnosis: decreased plasma cortisol level, ACTH high primary, ACTH low secondary. So in primary, the ACTH is high is the one that you have hyperpigmentation. In the secondary, that you don't have ACTH because the ACTH is low, you don't have hyperpigmentation. ACTH provocation test: serum cortisol level increase following the stimulus is adrenal cortex normal, abdominal CT or MRI to evaluate adrenal gland size. You have to do CT always because if you have a tumor, you have to do a surgery. Adrenocortical insufficiency treatment replaces the action of deficient hormones in a manner that mimics natural production. Two-thirds of the daily doses given in the morning and one-third in the evening. Stressful situation, illness, injury, surgery may need increased dose. Adrenocortical insufficiency, Addisonian crisis, acute adrenal insufficiency, life-threatening condition by inadequate level of glucocorticoids and mineralocorticoids leading to circulatory collapse. May occur with acute withdrawal of corticosteroid or may be caused by periodic of stress trauma. Treatment: intravenous glucocorticoids and volume replacement. And we have question number 2. A patient have a low cortisol level from autoimmune destruction of the adrenal gland. Which diagnosis with the nurse observed documented on the chart? What's the answer? What's the answer? The answer is D. Addison disease. Okay, low levels of cortisol, Addison disease. Okay, Cushing disease is excessive level of cortisol. Creatinine is low, is hypothyroidism due to lack of iodine. And pheochromocytoma is a tumor of the adrenal medulla and produce epinephrine and norepinephrine. Congenital adrenal hyperplasia, adrenogenital syndrome, that's common in newborns. Okay? Pathogenesis, lack enzyme for cortisol producing because of gene defect. Elevated ACTH secretions lead to adrenal hypertrophy and overproduction of steroid precursor, which increase androgens, leading to masculinization of female and precocious puberty in male. Life-threatening in newborn because of inadequate circulation of cortisol. Treatment with glucocorticoids. Hypercortisolism. Etiology and pathogenesis. This is the Cushing disease or Cushing syndrome. Cushing disease, term only used for pituitary hyperstimulation of adrenal cortex secrete excess of cortisol. Cushing syndrome, term used to describe any other reason for hypercortisolism. Primary is a disease of the adrenal cortex. Secondary, hyperperfusion of anterior pituitary ACTH circulating cell. Tertiary, hypothalamic dysfunction or injury. Hypercortisolism etiology, microadenomas of adenoma causing excessive production of pituitary ACTH. Non-pituitary tumors can cause ectopic ACTH production. Exogenous steroid use is the most common cause of Cushing syndrome in the United States. One of the cases of Cushing syndrome could be the bodybuilding. Okay, the bodybuilders, they use a lot of steroid and basically they have Cushing syndrome. Hypercortisolism clinical manifestations: round face with flushed cheeks, that's called the moon face. Weight gain with excessive total body fat, particularly in the abdomen, in extremities, cervical fat, capillary friability, thin skin with formation of purple striae. That's extremely common in those patients. Purple striae. Ecchymosis over the abdomen, arm, and thigh, decreased muscle mass, muscle weakness, glucose intolerance, hyperglycemia. Remember that cortisol stimulates the secretion of glucose, and that produces hyperglycemia. And also cortisol, for your general knowledge, is also called the stress hormone, because when you are under a lot of stress, you start secreting cortisol. Clinical manifestation: hypertension, demineralization of the bone, osteoporosis, increased androgen production causing excessive hair production, acne, menstrual irregularity, emotional lability, anxiety, irritability, depression. Diagnosis: ACTH measurements: primary, low ACTH; secondary, high ACTH. Plasma cortisol increase. 24-hour urine-free cortisol levels is increased. Dexamethasone suppression test is the one that is used to distinguish between the pituitary and ectopic cause. Hypercortisolism treatment based on etiology, exogenous dose reduced, transethmoidal hypophysectomy. That's when you remove transethmoidal is when you remove a tumor from the pituitary gland. Unilateral adrenalectomy, radiation, chemotherapy agents block cortisol production. Hyperaldosteronism, remember hypercortisolism have hypertension but is more related with glucose. Hyperaldosteronism is more related with hypertension. Primary is Combs syndrome, usually caused by aldosterone secreting tumor. Secondary, typically poor kidney perfusion that stimulate the renin-angiotensin-aldosterone cascade. Heart failure, reduced kidney perfusion, liver cirrhosis. Hyperaldosterone facilitates salt and water retention by the kidney with resultant potassium excretion. The classic presentation of this patient, the clinical manifestation, that means the clinical presentation of those patients is hypertension, hypervolemia, hypokalemia, and hypernatremia. Sodium is high and potassium is low. Treatment: spironolactone to increase sodium excretion and potassium retention. Sodium secretion and potassium replacement may also be necessary. Pheochromocytoma. Pheochromocytoma is a tumor of the adrenal medulla and that secrete catecholamines. The catecholamines are norepinephrine and epinephrine. Okay, pheochromocytoma, adrenal medullary tumor, result in excessive production or release of catecholamines. Clinical manifestations in pheochromocytoma, those patients have hypertension. The hypertension is intermittent. Okay, most of the time is intermittent. They have headache, tachycardia, diaphoresis, tremor. Diagnosis: you have to do abdominal CT or MRI to see the tumor. Okay, treatment: sympathetic blocking medication to manage blood pressure and surgical removal of the tumor. Surgery is the only curative therapy. In pheochromocytoma, when you are gonna do the surgery in those patients, you have to give alpha blocker, then beta blocker. Okay, never give beta blocker first to those patients because you worsen the condition. First alpha blocker, then beta blocker, then do surgery. Parathyroid gland disorder. Okay, remember that we have the thyroid gland, and behind the parathyroid gland we have like from 4 to 6 little dots that they look like fat. Those are the parathyroid glands. Okay, parathyroid glands located in the upper and lower detect serum calcium concentrations and help maintain constant levels through the regulation of calcium absorption and reabsorption from bone. Calcium needs vitamin D to be reabsorbed if vitamin D deficiency impairs calcium absorption. Parathyroid regulates action of parathyroid hormones. Serum calcium level provide the feedback to regulate parathyroid hormone secretions. Decrease in calcium cause PTH release. Elevation in calcium decrease the PTH secretion. PTH action: important regulator of serum calcium level. Act on bones, intestines, and renal tubules to increase calcium level. In bone, increase osteoclastic activity, release calcium into extracellular fluids, increase renal calcium reabsorption, and increase phosphate excretion by the kidney. That's why some way to remember the PTH is phosphate trash hormone. You say like this: phosphate trash hormone because they get rid of the phosphate. Okay. Calcitonin produced by thyroid parafollicular cell also influence the process of calcium by bone cell. Calcitonin decrease calcium, calcium tone down. That's how you remember it. Calcium tone down, calcitonin. Calcitonin increase bone formation by osteoclast and inhibit bone breakdown by osteoclast. Osteoclast being building the bone, that means that you get the calcium from the bloodstream and put it back to the bone. Then you decrease the calcium in the blood. Calcitonins decrease blood calcium level and promote conservation of hard bone matrix. Hyperparathyroidism, etiology, and pathogenesis cause idiopathic genetic parathyroidadenoma, hyperplasia, and parathyroid gland. Chronic renal failure, reduced vitamin D, bone reabsorption and formation rate are increased. Excessive parathyroid gland secretion rarely causes hypercalcemia crisis. Malignant cells can release PTH-like hormone, PTH related peptide. That's how that is called. PTH related peptide, and is common in patients that have lung cancer. They secrete like something that is related to PTH that produce paraneoplastic syndrome. Okay, we have hyperparathyroidism, etiology, and pathogenesis. Despite an elevated calcium level, PTH continues to be secreted. During pregnancy, it can lead to perinatal and neonatal complications. Newborns' PTH production will be suppressed by maternal hypocalcemia, leading to neonatal hypocalcemia and tetany. Some drugs, such as lithium and thiazide, can increase calcium levels. Hyperthyroidism, clinical manifestations: kidney stone, bone demineralization, osteoporosis, polyuria and dehydration, anorexia, nausea, vomiting, constipation, bradycardia, heart block, and cardiac arrest. Manifestations result from high serum calcium level and bone demineralization. High serum calcium level decrease neuromuscular excitability. Hyperparathyroidism diagnosis: primary hyperparathyroidism, serum calcium level elevated with low to normal phosphorus, urine excretion of calcium and phosphorus are elevated, serum PTH level are elevated. In this case, it's not like the thyroid gland, okay? In hyperparathyroidism, PTH is high because that's the hormone that you secrete, PTH. Treatment: surgical removal of parathyroid glands, hydrations to prevent stones, and ambulation to maintain bone density. For hypercalcemia crisis, repeat rapid volume expansion with normal saline diuretic. 0.9% that's the normal saline. Hypoparathyroidism, etiology and pathogenesis may be idiopathic, autoimmune, secondary parathyroid, or thyroid surgery, may be temporary or permanent, can occur with removal of parathyroid glands, congenital lack of parathyroid tissue, and idiopathic hypoparathyroidism are causes of hyperparathyroidism in children and infants. Clinical manifestation: circummolar numbness, paresthesia of the distal extremity, muscle cramp, spasms, fatigue, hyperirritability, anxiety, depression, prolonged QT interval, thus in the EKG, increase in intracranial pressure, severe symptoms, carpal spasm, laryngospasm and seizure, tetany, Charcot and Trousseau sign. Trousseau sign is when you put the cuff in the arm and that produces like a spasm in the forearm and fingers. Manifestation result from low serum calcium levels, increased neuromuscular excitability. Hypoparathyroidism diagnosis: serum calcium low, phosphorus high, antibody to parathyroid glands present if antibody mechanism involved, autoimmune mechanism involved. Treatment is acute hypocalcemia crisis, tetanus, laryngospasms of convulsion, IV calcium, and calcitriol. And calcitriol is a vitamin D. Okay? An activated form of vitamin D, long-term treatment, oral calcium supplement with vitamin D. Diabetes insipidus is a type of diabetes. We have 4 types of diabetes, and this is one of the type of diabetes. Diabetes insipidus, etiology and pathogenesis, insufficiency, ADH activity. ADH is antidiuretic hormones and is released by the posterior pituitary gland, is produced by the hypothalamus. Excessive loss of water in urine, damage to hypothalamus ADH production cell, brain injury, tumor, or procedures. Some pharmacologic agents means large diuresis of inappropriate dilute urine, central involve hypothalamus or pituitary, and nephrogenic involve the kidneys. Because diabetes insipidus, we have 2 types, central and nephrogenic. Diabetes insipidus, clinical manifestation, polyuria, polydipsia. In diabetes insipidus, you have the same sign and symptom of diabetes, but the glucose level is normal. Low urine specific gravity because the urine is dilute, and nocturia, hypernatremia because of water deficit, dry mucous membrane, poor skin to gore, decreased saliva and sweat production, disorientation, lethargy, seizures, manifestation from diabetes insipidus, diagnosis, dilute urine, high osmolarity, hypernatremia, along with abnormal low serum ADH level, diagnosis of central diabetes insipidus. Central diabetes insipidus, the ADH is low. In nephrogenic, ADH is high. Because in nephrogenic, the problem is that ADH in the nephron, in the kidney, we have B2 receptors for the ADH. That means that those B2 receptors for somehow have problem, and then you develop the diabetes insipidus. Water deprivation test with vasopressin, central diabetes insipidus, urine concentration increased, nephrogenic diabetes insipidus, little no response. Treatments: ADA with desmopressin, free access to fluid, hormone testing, or urine-specific gravity. And we have question number 3. And question number 3, which of the following laboratory results are consistent with diabetes insipidus? Who knows the answer? Micaela, B, perfect. Hypernatremia, that means that the sodium is high and low serum level of ADH. elevated serum of calcium and decreased serum of phosphorus, that's with the parathyroid hormones, high level of insulin growth factor 1, that's growth hormone, and decreased serum osmolarity and increased urine osmolarity. That's other disease that is related with ADH, but it's not diabetes insipidus, it's this one. Syndrome of inappropriate antidiuretic hormone, SIAD, etiology and pathogenesis, excessive ADH from ectopic production from tumor, notably primary lung malignancy. Excessive ADH stimulate renal tubules to reabsorb water despite decreased blood osmolarity. Adrenal insufficiency and hypothyroidism can cause increased ADH secretion and hyponatremia. Clinical manifestation: hyponatremia, high urine osmolarity, low serum osmolarity, weakness, muscle cramps, nausea and vomiting, postural blood pressure change, poor skin to gore, fatigue, anorexia, lethargy, confusion, hemiparesis, seizure, coma. Those are when it's extremely severe. Treatment treat underlying cause. Most of the time is related with tumor, so you have to do a CT scan. Free water restrictions is severe symptoms. IV administration of saline with diuretic is used. Hyponatremia should be corrected slowly to avoid rapid change in brain cell volume. When you correct the sodium in any patient, you have to be very careful, because when you go too low to high, the patient could die. When you go from high to low, the brain will blow, that produce edema in the brain. If hyponatremia persists, drugs such as lithium may be used to block the effect of ADH. And we finish right here with chapter 40. Any question? No questions? Perfect. Then let's go to the next chart. Listen, those disease, syndrome inappropriate antidiuretic hormone secretion, and the other one, diabetes insipidus, those are really, really hard to diagnose, okay, because are extremely similar. In real life, are really complicated. You have to read, and read again, because it's really hard to get the concept. Okay, now we go to chapter 41, and it's diabetes mellitus. Let's keep going. Energy, nutrients, metabolism. Energy required met by glucose and fat. Glucose produced from endogenous glycogen storage in the muscle and liver. Glycogenolysis. Glycogenolysis means the extraction of the glycogen. Okay? You do glycogenolysis to produce glucose, or manufacture from such substrates of amino acid, lactic, and other substrate. Gluconeogenesis. Gluconeogenesis is the formation of glucose. Okay? Glucose supplied to the bloodstream from the gastrointestinal tract and liver. Number of those diagnoses continues to rise. Number of persons with diabetes that have not been diagnosed continues to rise. Nowadays, diabetes is basically a pandemic, okay? Basically, no, it's a pandemic worldwide, because there is a lot of cases of diabetes. And here in the United States, we have a lot of cases, okay? Because there is a lot of fast food. The lifestyle of the people is not the best. The cost of the healthcare system continues to rise. Persons with diabetes are at greatest increased risk for blindness, renal, heart disease, amputation, and complication in pregnancy. The most common cause of non-traumatic amputation in the United States is diabetes. Okay, diffusion of glucose into the cell is controlled by glucose transport, GLUT1 to 4, specific to each tissue. Neurons and erythrocytes use GLUT1, do not require insulin. Heart, adipose, and skeletal muscles cells require insulin and activate glucose transport GLUT4. Activated glucose transport translocate to cell membrane, facilitate glucose diffusion into the cell. Hormonal regulation. Insulin is synthesized in the pancreas by the beta cell in the islet of Langerhans. Beta cells produce proinsulin storage in granules where it is cleavage into the insulin and C-peptide. C-peptide is really important, okay? Because that's how you distinguish person that is administering insulin to themselves and person that uh, have problem with the insulin. Alpha cell produce glucagon and delta cell produce somatostatins. F cell produce pancreatic polypeptide. Hormone regulation. Glucose is a stimulus from insulin release. Glucose enters beta cell passively through GLUT1 and 3 carrier. Glucose triggers a cascade of events that result in exocytosis of vesicles containing insulin. Insulin binds to its receptor on insulin-sensitive cells and triggers glucose uptake through GLUT4 carrier. This slide is pure physiology. Insulin actions enhance protein synthesis and prevent muscle breakdown. Inhibit gluconeogenesis. Remember that gluconeogenesis is the formation of glucose, and the function of the insulin is to get the glucose and make glycogen. Enhance fat deposition by preventing fat breakdown, lipolysis, and inducing lipid formation. It stimulates growth by enhancing secretion of insulin growth factor 1. Don't get confused somatomedin with somatostatin, okay? Those are completely different hormones. Hormonal regulation. Glucose is ingested food cause a brief rise in insulin release. First phase. Continued glucose cause the second phase, insulin secretions. Ingestion of nutrients stimulates release of glucose-dependent insulinotropic polypeptide and glycogen lipeptide from cells in the gut. Effect of blood glucose known as incretin effect. There is a lot of medications that the target of those medications is those hormones right there, GIP and GLP-1, and incretins. Hormonal regulation. GIP and GLP-1s stimulate the production of insulin, and GLP-1 inhibit glucagon. Insulin stimulates diffusion of glucose into the adipose muscle tissue, inhibit production of glucose by liver. Glucose oxidates in the cell glycolysis and used primarily for glycogenesis. Glycolysis is the extraction of the glycogen. Glycogenesis is the production of glycogen. Production of glycogen in the liver and muscle. Hormonal regulations. In the fasting state, glucose is produced by glycogenolysis and gluconeogenesis, and insulin falls to basal level. Glycogen is responsible for most glucose production in fasting state. Other counter-regulatory hormones, corticosteroid, growth hormone, catecholamines, augment glucose production. Exercise. Initially, insulin levels drop and glycogen and catecholamines levels rise, increase production of free fatty acids, and stimulate glycogenolysis. Glucose from liver meets energy demands, muscle contraction increase insulin sensitivity, maintain normal blood glucose level, and presence of lower insulin levels. Stress hormones, corticosteroids, and catecholamines increase production of glucose in the liver and glucagon, and decrease the utilization of glucose. Catecholamines increase production of free fatty acids and inhibit glucose uptake in the periphery. All these events lead to stress hyperglycemia. Can also occur with psychological stress. Listen, sorry for those slides. Those slides are pure physiology, but you have to know physiology. We have to refresh the physiology to understand the pathophysiology. Okay, I'm trying to go in, just touching the most important points to get into the real material that is the pathophysiology. But you have to study this at least for the quiz for this week, okay? And for the final, also this is gonna go to the final, but I'm making a review for the final, okay? I'm gonna try to finish the review for the final for the next week, okay? That you have time to study. And also in that review, I'll let you know if you have to know something about this, okay? Most probably not. Classification of glucose intolerance disorder, type 1 diabetes mellitus and type 2 diabetes mellitus. Classification of glucose intolerance disorder. I don't know why they call like that, because glucose intolerance is type of diabetes type 2. Other specific type of diabetes mellitus and gestational diabetes mellitus. Those are the four type of diabetes. Diabetes type 1, diabetes mellitus type 1, diabetes mellitus type 2, gestational diabetes, and other diabetes. Those are the type of diabetes. The diabetes class is, I don't know, sometimes the people don't, there are a lot of doctors that don't believe in pre-diabetes, but we have a classification of pre-diabetes. Impaired glucose tolerance, 2-hour post glucose value of 140 to 200. You are between 140 to 200, then you are pre-diabetes. If you are over 200, that's diabetes. In fasting, if you are from 100 to 125, that's pre-diabetes. In those patients, you have to do lifestyle change, exercise, diet, diabetes mellitus, endocrine disorder, diagnosis by the presence of chronic hyperglycemia. Diagnosis if any two of the following conditions occur. Random sampling of blood glucose above 200, that's done. That's diabetes. Fasting glucose level greater than 126, diabetes. In this one, the fasting over 126, you have to measure 2 times, okay? And blood glucose concentration greater than 200, 2 hours after 75 grams of oral glucose low. That's the glucose tolerant test. And hemoglobin's A1C levels above 6.5. Here in the United States, we measure a lot of this one right here. is really useful in the clinic, okay, because that gives you an idea if the patient is compliance with the medication, okay. For your future life as a nurse, you have to keep this in mind, and it's a tip for you as a future nurse, not right now, okay. When you have a patient with diabetes, those patients are sometimes are extremely hard, and you have a lot of difficulty treating those patients. What happens? The patient know that, for example, tomorrow they are gonna get measurement of the glucose, and what they do the day before, they don't eat anything. They have a fasting for like 24 hours, and when they go to the hospital, that they measure the fasting glucose is gonna be normal most of the time. Then you measure this hemoglobin glucose, and that gives you an idea how was the glucose in the last 3 months, okay. So if the fasting is normal and this one is abnormal, that means that the glucose is high in that patient and is not complying with the medication, okay. Let's keep going. Prediabetes: impaired glucose tolerance and impaired fasting glucose tolerance, intermediate stage between normal glucose metabolism and diabetes. Diabetes type 1 mellitus, characterized by destruction of the beta cell of the pancreas, usually diagnosed between 5 and 20 years of age, normally from 5 to 10. Etiology may be immune-mediated or idiopathic, without autoimmune marker or HLL associations. Autoimmune marker: chromosome 6, HLL, and HC genes. Type 1 diabetes mellitus result in absolute insulin deficiency. That's why those patients has to go straight to insulin. Overproduction of glycogen stimulate glycogenolysis and gluconeogenesis. Glucose level rise, leading to polyuria, increased urine, polydipsia, 30, and polyphagia, hungry. Classic sign. Weight loss. That's another classic sign for this diabetes. Type 2 diabetes mellitus, most common form of diabetes on Caucasian and elderly. Disproportionate effect: insulin resistant and beta cell dysfunction lead to relative lack of insulin. Suspect decreased number of insulin receptors and abnormal translocation of glucose transporters. As disease progresses, insulin production may be impaired. Listen, glucose intolerance, the the pathophysiology behind glucose intolerance nowadays is not well understood, but there is a couple of uh, concept that in medicine we already prove, but the most worldwide use is that what happens in those patients that is people that are eating, that are overweight, and what happens that you are burning your insulin basically because you are using too much insulin in your body, and at one point then remember that the insulin receptor to put glucose inside some tissue, so at one point those receptors may resistant to the insulin, and then the glucose, instead of going to the inside of those cells, they start hanging around in the blood, and then you develop the diabetes. And also you burn all your insulin, you are out of insulin, you destroy the pancreas, and then you develop the diabetes. Let me go back. Type 2 diabetes mellitus risk factor: female sex, obesity, aging, and sedentary lifestyle. That's extremely common here in the United States. Okay? People go to the mall, especially ladies, females, and they want to park inside the mall, not even close. They want to get inside the mall with the car. And That's not good, okay? Polyuria, polydixia, and polyphagia may be more soluble. In type 2 diabetes mellitus, you don't see the classic signs, okay? Other specific type of diabetes, various type of diabetes identified by genetic defect, tissue, autoimmune, blah, 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 blah. You don't have to worry about this because all those type of diabetes, all of them are including in type 2 diabetes mellitus. Because I think there are like 20 types of diabetes, but all of them are including type 2 diabetes mellitus because the treatment is the same. Gestational diabetes mellitus, disorder of glucose intolerance and variable severity with onset during pregnancy. Closely resembling type 2 diabetes mellitus, most likely precipitated by placenta hormones and weight gain, risk factors, severe obese, history gestational diabetes, previous offspring weighing more than 9 pounds at birth, presence of glucosuria, and a strong family history of type 2 diabetes. Gestational diabetes mellitus: all pregnant women older than 25 years old should be screened during 24 and 28 weeks. Is not, forget about this, the age, okay? Don't have to worry about the, let me put it right here. Okay, you don't, Zach, you don't have to worry about the age, okay? Forget it. I don't know why they put the age right here. You don't have to worry about the age. Doesn't matter the age. If you are pregnant from 24 to 26, you have to measure the glucose because that's a protocol in pregnant women, and we have to follow the protocols. Okay, we'll keep going. Complications in infants. The most common complications is metabolic anomalies, stillbirth, macrosomia. That's one of the most common. Most of the time, the baby is macrosomic, and neonatal hypoglycemia. People have a lot of questions. I mean, a student always have questions about this. Why hypoglycemia? Remember that during pregnancy, the mother, the glucose is extremely high, and the baby is secreting insulin. Once the baby is out, what happens? You don't have too much glucose, but you're still secreting insulin, and that's why those patients develop hypoglycemia. Mother developed of type 2 diabetes mellitus or impaired in glucose tolerance later in life. That one of the complications could be. Most of the time, the mother once they give birth, they are normal, go to a normal life. Management through dietary counseling, exercise, and blood glucose ketone monitoring. Insulin may be needed. That's the only medication that you use in pregnant woman. Insulin, okay? Actually, if you have a woman that have diabetes type 2 and they are taking metformin or any oral medications, you stop those medications and put the pregnant woman in insulin. Screening for diabetes: all adults older than age of 45 should be screening at least every 3 years for type 2 diabetes. Individuals with risk factors should be screening early or more frequently. No screening required for type 1 diabetes. Acute hyperglycemia, commonly caused by alteration in nutrition, inactivity, or inadequate use of anti-diabetic medication. Down phenomenon: rise in glucose in early morning hours from growth hormone, cortisol, glucagon, and epinephrine release. Symptoms: polyuria, polydixia, polyphagia, nausea, fatigue, blurry vision, and more prone to infections. Continued insulin deficiency lead to lipolysis. Let me see. Okay, now we are in another topic. This is diabetes ketoacidosis. Diabetes ketoacidosis is a complication of diabetes type 1. Okay, it's more common in diabetes type 1. Okay, continued insulin deficiency lead to lipolysis of body tissue, metabolism of fat lead to free fatty acid. Free fatty acid are transformed in ketones, and that is the one that produces the ketoacidosis, leading to ketoacidosis. Deep labor respiratory that are fruity in odor cause mouth respiration. That's the classic respiration in diabetes ketoacidosis. Excessive ketones result in metabolic acidosis. Ketoacidosis may occur with type 2 diabetes mellitus, but is not the most common. In type 2 diabetes mellitus, we have another complication. Okay, acidosis-induced hyperkalemia may occur. You have to be very careful with the hyperkalemia in diabetes ketoacidosis because it's not actually hyperkalemia. Okay, actually the total potassium in the body is decreased. Diabetes ketoacidosis, excessive potassium excreted through kidney, as is sodium, magnesium, and phosphorus, hypovolemia and dehydration, lactiacidosis, hypovolemic shock if untreated. No, this is the complication of type 2 diabetes mellitus, is the hyperosmolar syndrome, non-ketotic hyperglycemic hyperosmolar syndrome. Non-ketotic hyperglycemic hyperosmolar coma can develop more common in older adults. More common in type 2 diabetes mellitus, severe hyperglycemia may or not be slight ketoacidosis. Most of the time you don't have ketoacidosis. And strychnine dehydration, ketoacidosis is uncommon. Hyperglycemia may go untreated for a time and result in persistent glucosuria with osmotic diuresis. Can be life-threatening. Another big difference between diabetes ketoacidosis that in medicine is called who's talking? Who's talking? It's called DKA. Is that the glycemia, the glucose level is over 250 but no more than 500. In this one, hyperosmolar syndrome, the glucose level most of the time is over 500. It's in the 600, 700, 800, could be 1,000. Chronic hyperglycemia. Give me 1 second. Let's keep going. Chronic hyperglycemia may lead to systemic change over time and increase the risk of other diseases, including metabolic syndrome, hypertension, cardiovascular disease, and stroke. Complications are categorized as vascular and neuropathic. Vascular complication, microvascular. We have two types. We have microvascular and microvascular. Okay, microvascular damage to large blood vessels lead to cardiovascular disease, peripheral vascular disease, and stroke. Preventive calorie restriction, exercise, possible drug control, dyslipidemia, and hypertension. Diabetes mellitus is an independent risk factor for coronary artery disease. Dyslipidemia, hypertension, and impaired fibrinolysis are present in uncontrolled diabetes mellitus, improved with blood glucose control. Microvascular retinopathy and nephropathy from abnormal thickening of the basement membrane in capillaries may lead to blindness and renal failure. Hyperglycemia disrupts platelet functions and growth of the basement membrane. Thickening of the basement membrane may improve with glycemic control. This is improved with glycemic control. high glycemic control. If you have a high glycemic control, you improve this one, but you don't improve the other one, okay? Urine protein loss occurs in nephropathy. Prevented control blood glucose and hypertension. Neuropathic complication, diabetes neuropathic, autoimmune autonomic dysfunction, GI disturbance, bladder dysfunction, tachycardia, postural hypotension, and sexual dysfunction. Secondary dysfunction include carpal tunnel syndrome, peristalsis in extremity, especially feet. Listen, in diabetes, the first neuropathy that you have is this one, in the extremity. Okay, the neuropathy in diabetes is start distally, that means in the extremity, and they go proximally, that means in the inside, in the GI, in the bladder. Neuropathy complication, excessive glucose is thought to interfere with myoinositol in neurons and reduce myoinositol in peripheral nerve. Hypertriglyceridemia, obesity, smoking, and hypertension enhance development of neuropathy. Glycemic control may prevent or improve symptoms of diabetes neuropathy. And we have question number 1. A patient who is diabetic has a lesion on the foot but does not know how it occurred and has paresthesis. Which type of chronic complication is the patient having? What is the question? The question is secondary neuropathy. Perfect. Thank you. C. That's the question. That's the answer, I mean. Complication in pregnancy, type 1 diabetes mellitus, higher risk of perinatal infants mortality and congenital anomaly. Glycemic control before conception and during pregnancy may reduce this risk. Goals: achieve metabolic control of blood glucose, preprandial blood glucose level between 70 to 100, postprandial 180, preventing acute or chronic complications accomplished by diet, exercise, medication, and such hygiene practice of daily food care and smoking cessation. Nutrition, cornerstone of diabetes therapy, may involve changing the composition of the diet, meal pattern and timing, and caloric consumption. Attention to energy consumption and energy expenditure. Obesity and eating disorder. Obesity, strongest risk factor for diabetes mellitus. Body mass index over 30. If your body mass index is over 25, you are overweight. Over 30, then is obesity. And I think over 40 is morbidly obese. Recommendations include a nutritional complete diet, program of maintenance, and exercise. Bulimia and anorexia may be more common in type 1 diabetes mellitus. Carefully assessment is warranted. Bulimia and anorexia, those are eating disorders, okay? And eating disorder that people that don't eat, don't like, don't want to eat, and most of the time are psychiatric disorder. Exercise recommended for all type of diabetes mellitus, 20 to 45 minutes, at least 3 days a week. Lower cardiovascular risk factor may be beneficial toward weight reduction and maintains. May lower medication required for type 1 and type 2, may prevent type 2, and so on. Exercise is basically the best medication for type 2 diabetes mellitus. It's the best medication. Walking not 5 miles, like 3 miles a day, that's the best medication. Exercise should be avoided if ketosis is present, can lead to increased hyperglycemia. When blood glucose value over 250, safe to safe is ketone not present. Oral antidiabetic agents for type 2 to achieve recommended A1C of less than 7%. A1C is the hemoglobin glycemia. Sulfonylureas induce insulin release by beta cell, augment the action of insulin in glucose disposal, diminish insulin clearance by liver, and reduce hepatic glucose production. Sulfonylurea, you have to be very careful because it's a strong medication. B1Is suppress hepatic gluconeogenesis and enhance glucose uptake by peripheral tissue. B1Is, that's the metformin, the famous metformin. Oral antidiabetic agents, alpha-glucosidase inhibitors diminish postprandial hyperglycemia by delaying carbohydrate absorption. Thiazolinidones increase tissue sensitivity to insulin and inhibit hepatic glyconeogenesis. Those medications basically are not used here in the United States, especially there is one that is produced probably in the heart. Incretins and amylins. Incretins inhibit enzymatic breakdown of the incretin hormones GLP-1 and GIP. Those are the new oral medication for the treatment of diabetes. Amylins mimic agent used in conjunction with insulin for the management of glycemia. Effective in weight loss and lowering A1C when used in conjunction with other diabetic medication. Insulin for type 1 diabetes mellitus, 100%, replace deficient hormones, different type, rapid-acting, short-acting, intermediate-acting, and long-acting, different dose scale used to mimic normal insulin release, injection, pump, jet, pen, long-acting insulin, glargine and determine, and rapid-acting aspart, lispro, and glucinin commonly used. Hypoglycemic complication cause insufficiency food intake. That's why when you give insulin to the patient has to eat always. If you are not gonna eat, don't take the insulin because maybe you have this hypoglycemia. And hyperglycemia is a complication, but hypoglycemia is an emergency. Okay, people die from hypoglycemia. And if you want to see a patient with hypoglycemia, is basically drunk. And the patient, when you see a person that is extremely drunk, that's the patient with hypoglycemia. That's the same presentation. Contrarregulatory mechanism symptoms: pallor, tremor, diaphoresis, palpitation, anxiety, neuroglycopenic symptoms: hungry, visual disturbance, weakness, paresthesia, confusion, agitation, coma, death, and have hypoglycemia unwarranted. We have question number 2. A patient with type 1 diabetes mellitus is pale, has tremor, and has diaphoretic. What does the nurse suspect the patient is experiencing? What's the answer? A. Hypoglycemia. Listen, hypoglycemia is basically a patient that is drunk. They are completely confused. They not even know their name. They are talking like that. It's basically a drunk person. Okay. Once you give sugar to the patient, you give glucose to the patient, automatically the patient, most of the time, the patient get better and start talking like normal, acting like normal. Other complication of insulin therapy: lipoatrophy. Lipoatrophy, those are problem in the skin. That's why you have to, when you put the injection, you have to rotate the side of the injection because this is one of the complications. Lipohypertrophy is the same. Insulin edema, generalized accumulation of fluids. Insulin resistance exacerbated by obesity may need more insulin. Stress management, management of diabetes mellitus can be stressful, especially when you have type 1, that you have a baby and you diagnose, the child with diabetes type 1 is extremely stressful for the patient and for the family because you have to educate the parents. Patients with diabetes mellitus are high risk of depression, play an important role in improving quality of life and reducing impact of stress at glycemic control. Remember that stress increases the glucose, so you have to educate the patient. The patient has to be calm down, relax to have a better outcome. Assessment of efficacy, glycosylated hemoglobin to determine long-term glycemic control and evaluate the therapy goal, OA1C, glucose freely attached to RV, red blood cells, so on. That's why you measure 3 months because when you measure this, you are measuring the glucose that is attached to the red blood cell, and the lifespan of the red blood cell is this. It's like 4 months, 3 to 4 months. Cap glucose testing for ketones through urine testing if glucose more than 3, pregnancy. Education, considering a special part of diabetes treatment, increase patient knowledge about diabetes, improve performing of self-care procedures, and psychological outlook. Must be tailored to the individual's needs. Guide by national standard for the assessment, setting and objective follow-up, and other areas. Golf therapy achieve normal growth and development, avoid acute and chronic complications, addressing psychological issues, educating children regarding self-care, acute complication, dehydration, diabetes ketoacidosis, when blood glucose if more than 200 or during illness, test for ketones, hypoglycemia may be difficult to detect, suitable behavioral change, lethargy, pallor, sleep disturbance, chronic complication rarely manifest before adolescence, screening for neuropathic ongoing, counseling of metabolic control before initiating of pregnancy. Treatment insulin requirements are typically 1 unit per kilogram per day, usually at least 3 injections a day, increase during period of stress, abdomen site least preferred. Insulin need will vary according to growth stage, exercise, and intercurrent illness. Child and family need ongoing education and support. Crucial. Treatment, age at which children performing insulin measurements, administration and glucose monitoring independently will vary. Calorie intake, need for energy expenditure, growth, and maturation. You have to be very careful with the activity of the patient, what they eat, and the amount of insulin that you are giving, okay? Because be a hyperglycemia or hypoglycemia, increased prevalence of type 2 diabetes mellitus, increased adipocyte, decreased lean body mass, decreased activity level, decreased insulin secretion, hyperglycemic state of certain medication. Those are problems consideration in geriatry. Geriatry is elderly patient. Okay. One of the most important consideration in elderly patient is that you have to measure the neuropathy, okay? They have to take care of their foot, okay? Their extremity, because if they develop neuropathy, they are not gonna feel anything, and maybe they develop an ulcer. Acute complication, hyperglycemia, often asymptomatic, dehydration, increased risk of infections, non-ketone hyperglycemic hyperosmolar coma. Hypoglycemia may be atypical and can lead to injury. Chronic complication, heart and blood vessel disease, foot disease, eye disease, kidney disease. Those are the tissues that are always affected. Okay? Why? Because those tissues, they lack of one enzyme. That's why the insulin is accumulate in those tissues and produce a lot of damage in the heart, eyes, and kidney, and in the peripheral nerve. Treatment oral agents should be chosen carefully considering renal and hepatic function. Always you have to measure the renal and the hepatic function. Renal for metformin, because metformin is renally secreted by the kidney. That's why you have to measure the renal function when you give metformin to the patient. Short-acting oral agents are preferable. Insulin therapy may require adaptive device, exercise and meal planning, and so on. And we have the last question. The last question is, which of these patients is most at risk for non-ketotic hyperglycemic hyperosmolar coma? What's the answer? And 9 years old, just because of the age, is out. 37 women with gestational diabetes is not the most common one. The most probably answer is C. That's the answer. C. 76 years old man with type 2 diabetes mellitus, and they have the flu. Why? Because flu produces stress, and the stress increases the glycemic, and then they develop the complication. Any question? We finish right here. Any question? Hello? Hello? No question? Perfect. If you don't have any question, please, you are free to go and study for the test, okay? If you have any problem, just let me know, okay? The same for all of you. Have a great night, great weekend. Enjoy your weekend, but study. Okay? Let me stop right here.